All right, I think it is time that we go ahead and get started because we have a packed agenda for today. We have a lot to get done within the hour, so let's go ahead and jump right in. Thank you everyone for joining today. My name is Hannah Tessema. I am a Senior Monitoring and Evaluation Advisor here at Palladium. I've been working in the field of HIV for the past 18 years now, nationally as well as locally in New York City and other places throughout the country. Leading national training, technical assistance, and capacity building programs in places throughout the country that have the highest incidence and prevalence of HIV. Also conduct research on PrEP uptake among Black women. I'm here representing Palladium, a global impact firm working to advance health equity through meaningful community engagement, as well as partnership. We have staff across 31 US states here in Washington, DC, where we're based, and 90 countries throughout the world. We have nearly 60 years of experience improving health outcomes and reducing health inequities in the communities that we serve. Our primary areas of focus in the US are HIV/AIDS, maternal health equity, and pandemic preparedness. We are very pleased to be co-hosting this event to commemorate Southern HIV/AIDS Awareness Day alongside NMAC's Coalition for Justice and Equality Across Movements and AIDS United's Melanated Movement. So I will pass the mic to Tony Newman first, and then Carly Gray to introduce themselves, and then we will jump into our agenda. Tony, you are on mute. Tony, can you hear us? Tony might not be able to hear us. Carly, do you want to introduce yourself in the meantime while we
Yeah, for sure. Hello, everyone. I am Carly Gray, and I work at AIDS United within the programs department across several programs, but including Melanated Movement, which centers on uplifting the narratives of Black women of all experiences living with HIV, inclusive of where gaps in care are, including wellness, just putting the word out there to give people the platform to construct their own narratives and highlight what life beyond diagnosis is like. All these sorts of things. And through Melanated Movement, we also work with the Southern HIV Impact Fund, which really we are able to use those experts to give us this lens on what's needed for Black women living within the South in the US who are experiencing different things related to HIV. And so I am so excited to be here amongst Palladium and the Coalition for Justice and Equality. And yes, I will turn it back over to Tony. Oh, I think you're on mute now.
Oh, apologies. I was saying thank you, Carly, and we'll just give Tony a second to see if she's able to come off mute. I was trying to do it on my end. Oh, did it work? Maybe not. Okay. All right, so Tony will join us in a second. Let's jump into the context slides because I want to make sure that we give our panelists enough time to speak. So, okay, so let's move on to the next slide, please. So we just wanted to begin by kind of setting the context here, take a moment to very quickly show you this map, which comes from AIDSview, one of our very most favorite sources of data and infographics. It very clearly shows the Southern US is disproportionately affected by HIV. This is especially true among communities of color. In the South, over half, 52% of new HIV diagnoses occurred among Black people and 22% among Hispanic or Latinx. There are many drivers of health disparities like this in the US, including challenges with accessing high quality and gender affirming care, lack of Medicaid expansion in multiple southern states, including Tennessee, Mississippi, Alabama, Texas, Georgia, South Carolina, and Florida. We have representation from many of these states among our distinguished panel this afternoon. There are also harmful policy agendas, continued HIV stigma, racism and discrimination, the social determinants of health, poverty, food insecurity, housing issues, among many others. So our panelists will get into some of these issues and how they affect women and LGBTQ plus communities in the South in just a few minutes. A couple more slides. So looking at this infographic here, the next slide, we see that the South accounts for more than half of all new HIV diagnoses, yet only represent 38% of PrEP users, right? So there's a substantial unmet need across multiple groups, especially among communities of color and women who only represent 8% of people using PrEP. Next slide. In 2021, almost half of all deaths among people with HIV also occurred in the South. And when we looked at the 10 states with the lowest rate of viral suppression, 7 of them were in the South. So next and final slide from me. So that brings us to Southern HIV/AIDS Awareness Day that was founded by the Southern AIDS Coalition in 2019. It is commemorated on or around August 20th each year. And it's a call of attention to the disproportionate number of people living with HIV in the South. So next, I want to pass it along to our panelists. After our panelists have spoken, we'll allow some time for Q&A. You'll notice there's a Q&A box. Please type your questions there, and we'll have time for that at the end. I would like to pass it to Tony to introduce our first panelist, but I don't know if Tony's been able to get off. Let's try.
Hi, I'm here.
Yes, it worked. Okay, so on to you, Tony.
Okay, thank you. Glad to be here, everyone. I'm Tony Newman, just in case, from NMAC, the director of the Coalition for Justice and Equality. I'm introducing Mia Cotton, is the Chief Program Officer at Friends for Life. It's a community-based organization in Memphis, Tennessee that provides wraparound clinical and supportive services to people affected and infected by HIV and AIDS. In 2007, Mia started her professional career in HIV and AIDS with the Methodist Lee Banhar, doing street outreach and case finding in the Latinx community. 3 years later, in 2010, she begins employment at Friends for Life as a case manager and has steadily advanced her career within the organization. She has a bachelor's and master's degree from the University of Memphis and Walden University, and she serves as the chair of the Memphis and Shelby County Homeless Consortium Planning Committee. I now present you to Mia Cotton. Thank you.
Hi, thank you, Tony. Hi, everyone. I just want to make sure, you guys, I have 10 minutes, correct?
Yes, exactly.
Okay, you know, I'm a talker, so wait a minute, let me set my timer so I make sure I don't cut into anyone else's time, but I just wanted to be sure. Hi, everyone. Thank you, Tony, for that wonderful introduction. My name is Mia Cotton, Chief Programs Officer at Friends. We were previously Friends for Life. We are now Friends for All. That is new for us. That is our nod at inclusion and trying to be more status neutral in the services that we provide for everyone. Because one of the biggest challenges that you're going to find in the South is stigma, amongst all the other things we have going on. But stigma is a big problem in making sure our folks are taken care of. So we are working on making our services as inclusive as possible so no one feels singled out. Some of the challenges I want to talk to you all about in the South that we have recently experienced. There are some anti-LGBT legislation that has come through that are affecting our folks, as well as one of our, we had a huge situation with our funding around prevention services. I'm going to talk in a little bit more depth about that, as well as future concerns around ongoing funding and new concerns around our Ryan White Part B funding in the state of Tennessee and how all of that will be affected. So my expertise is around the HIV care and prevention components. I've been doing this for a while. The policy piece, this is new for me because I was thrusted into it because our governor was a very busy bee this year. So I am learning as I go along. And so I am gracious for this opportunity to be able to speak. So one of the anti-LGBT laws we had was around an anti-drag bill where drag could not be performed anywhere in a public vicinity. I am located in Memphis, Tennessee, Shelby County, in which we are probably one of the epicenters in the South for new HIV infections. So we are the blue-haired stepchild of the state. So we tend to always rally around when it comes to things like that. So that anti-drag bill that was passed, it is passed, but our district attorney has not allowed it to be enforced at this point in time. So yes. The second one that was really crucial and severe to us was around gender affirming care for our youth. It has now been made illegal under 18, and parents can be prosecuted for assisting their child in making this transition. So right now we are in a scramble. This is still happening. Families are trying to figure out what they are going to do, and lawsuits and fights are going on to see if we can prevent this from happening or repeal this. So those are just some of the policies, the anti-LGBT policies that we are dealing with in our state of Tennessee. The next component I wanted to talk about was what I was more involved in, which was the rejection of our CDC funding for HIV prevention. As I told you, we are in the top 3 for new HIV infections. I do not have official data, but I do think Shelby County, Memphis has been moved to number 2. So we don't have that official data being released, but we do know we are in the top for new HIV infections, not only in our state of Tennessee, but for cities our size. And so our governor rejected $9 million from the CDC to provide prevention and outreach services to target populations. This happened in January, and what was very complicated for a lot of the CBOs involved in this situation was we had already been providing services around this funding starting in August. And so we were pretty much told midstream that this funding would go away. Our dollars for the current grants were cut, and we were told that funding would not be available. All of our funds were operated through the United Way of Greater Nashville, and they were managing the funds for the state. They were the fiduciary. So we had to do a lot of community mobilization because that's $9 million that we are using for testing, PrEP and PEP services, behavioral-based interventions, linkage to care, all of those things that we would utilize to prevent people from becoming positive, because we know prevention is also, making sure people know their status and case finding is critical. If people know their status, we can get them in care, we can get them undetectable, U equals U. So this is a very crucial component in us ending the epidemic, and the loss of these funds would have prevented us from doing this. So of course, this was going to affect Black and brown people because we are disproportionately affected, like most of the South, by HIV and AIDS. And so what happened was all of the community organizations across the state, we came together. Thank you to Tony and NMAC, so AIDS United, Southern AIDS Coalition, all of these national groups, and I'm sure I'm leaving someone out, but they came. We had support from the White House, Congressman Cohen's office, our local leaders, political leaders were stepping up to help us. It was a convergence, and it happened very fast. Within about 2 weeks, the whole state had mobilized, and we started telling our stories and really talking about the impact if we lost these funds. One of the big concerns was there was always talk that the state was going to fund the programming, but through their own dollars. They didn't want federal assistance. So the state was going to find that money and provide those services. But the big concern that came with that is the science tells us where we need to target those efforts at. And there was an introduction of other not so risky groups being the target of these efforts. Women of childbearing years, human trafficking and sex workers. We know that's an issue, but not as large of an issue as African-American men who are having sex with other men, and now African-American women, not necessarily even of childbearing years. Also, first responders were at the very top of the list. And if you look at all the data, these are not high risk categories that these dollars need to be targeted at. Some of them need to be addressed, but it wasn't the heart of the epidemic. So that was a big concern early on. If the state did fund this, we were limited. At that point, we mobilized, we started talking, and within probably about 3 months between communications, the CDC was able to come up with a plan to be able to redirect funding without using the state health department, because their model goes through the state and then it's divvied out amongst the state. So we all agreed as a state that we wanted United Way of Greater Mid-South to continue to manage these funds. And so the CDC was able to work directly with United Way of not Mid-South, of Greater Nashville, and get those funds directed. Now, United Way was able to get half the funding. So they got about $3 to $4 million that would support all of the people who had been funded to do these services. After that, the state of Tennessee did come back through and they did appropriate $9 million across the state for prevention services. Now, some would say we came out better than what we started. Well, technically, yes, financially, we did. They identified 6 agencies across the state of Tennessee that would be the fiduciary for these funds. My agency, Friends for All, was one of those for our region. And we also not only support the HIV and STI work, but also our syringe exchange programs. They are now part of our purview, and we work to make sure they stay funded to do the work that they do. Now, some of the things that are problematic for this is we did neutralize, we did come together. We used media. Like I said, our national organizations were critical. And again, I couldn't be more grateful for all the support that they provided during this. But this is something that could be replicated. And this is something that we could see in other states in the South, which is why Tennessee was at such the forefront, because this could be a model. We could see Texas, we could see Florida, we could see Alabama, Mississippi following right along suit. But even with the state appropriation funds, those appropriation funds are annual funds. They are not multi-year cycles. Now, we have been told that they will continue to fund every year, but that has to be voted on by our legislatures every year. So there's no guarantee. And while we are grateful for the CDC for being able to move the way they did and be able to get the money rerouted to United Way of Greater Nashville, that is only a 1-year funding cycle. So I am confident that they will work together to figure out what that is for a multiple year funding cycle, because this was just like, we got to get money back to Tennessee. But we have just started our work. We need to be able to have these funds continuously. CBOs don't need to be worried from year to year. How am I going to continue to support these services? There were agencies that closed their doors during this time because they couldn't afford to pay for their spaces. Staff were let go. We were a little bit of a larger agency, so we kept our staff on, even though we didn't have the funding, with our fingers crossed that we were going to figure something out and that we would get something together. But we did that for our folks. Another big component that was hard for a lot of us is 340B, which is something that people really don't understand what 340B is. It is a pharmacy program in which you can, as a nonprofit, you can buy the drugs at wholesale price and you can bill full price, and then you take that money and put it directly back into your programs. One of our bigger projects that we have is our PrEP and PEP clinic. And we manage, last year, we kept about 800 people on PrEP last year, but we run that clinic solely on our probably about 75 to 80% of the funding that supports our free PEP and PEP clinic came from our 340B funds. And with the state taking away the CDC funding, it didn't allow us to have that designation. And that was the same for some of our other community partners across the state. Those 340B funds are critical to keep the operations going. So for us, the CDC funding was important, but what we get from revenue from our 340B and the designation we get from our CDC grant was more critical to us, because that was a bigger component. of what we needed. So one of the things that I'll close with here is this was a short victory. It was a victory. The funding came back to the state of Tennessee. The CDC funded us as well as the state directly funded us. But again, I cannot talk about how critical it is for us to continue to mobilize because this is only a short-term solution. We are only guaranteed funding from CDC until May of 2024 and from the state until June 30th of 2024. After that, we hope these funds will be renewed, but there is no guarantee on either side. The newer battle that we are starting to dig into, while our prevention funds were predominantly on our prevention side, but there are some care components that happen, especially when it comes to PrEP, PEP, STI treatments, and linkage to care for Rapid Start. Those are all treatment components that are tied into those fundings. But also now we are dealing with those same challenges with our Ryan White Part B programming, and that is starting to unfold. We know in the upcoming year that our Part B funding for the state of Tennessee will be cut. We are not sure exactly the magnitude of that yet. We are learning what that will look like, but that will be the next challenge, and that will directly affect care for Tennesseans across the state. Whew.
Thank you so much.
I got it all
Mia. Yeah. You did a great job. Thank you for spending your time. We appreciate it. Tony, on to our next panelist. Thank you.
Oh, thank you, Mia. Our next distinguished panelist is Kathy Ayers. She's the CEO of AIDS Alabama, a statewide nonprofit organization in Alabama that provides housing, mental health, substance use treatment, transportation, PrEP, and care clinical service, case management, peer support, food assistance, employment preparation, and many other services to low-income persons with HIV. Kathy was instrumental in modernizing both the Ryan White HIV/AIDS program in 2006 and the Housing Opportunities for Persons with AIDS in 2015, with legislation to make distribution of funding more equitable. Nationally, Kathy was the only resident of the Deep South selected in 2010 by President Obama to serve on the Presidential Advisory Council on HIV and AIDS, where she was elected to co-chair of the Disparities Community. I am now introducing you to Kathy Ayers. Thank you.
Thank you so much. Wow, Mia, you really have a lot to deal with in Tennessee. I'm glad you went first so that folks can get a taste of what it's like sometimes to live in the South. But thank you so much for joining us. I'll tell you just a little bit about AIDS Alabama first. I say that we're unusual in that we're a statewide organization. That's not true of most AIDS service organizations. So we actually, through partnerships or direct service, cover all 67 counties. And that's important to me because in the South, you have more rural area than in most of the country. And we all know that rural areas often get overlooked. So I think whether you live in Pineapple, Alabama or Birmingham, Alabama, if you need help, you should be able to get help. So that's one component of AIDS Alabama. We also have a major focus on housing. We believe that housing is healthcare. And we know through research that housing improves medical outcomes, increases viral suppression, and reduces new infections. So it's very important for us to remember housing when we're doing this HIV work. We also believe at AIDS Alabama in centering our HIV positive clients. They should be the decision makers, they should be in leadership, and they should be in all components of what we do. That's why we hire as many HIV positive folks at AIDS Alabama as we can. We're big believers in advocacy because, as Mia was describing in Tennessee, we all know how very much service on the ground is impacted by policies. So it's important for us to work to get the best laws and policies that we can for our clients. We also do a lot of mental health and substance use, which is critical, and clinical services. And I have to brag on our clinic down in Mobile, Alabama. We have about 2,000 patients there. About 1,000 are on PrEP, and 35% of those are cisgender African-American women. And I believe that we've had the success there that we've had because we utilize gatekeepers to the community. I think most people want to be served by people that look like them, and that's an important component of our work. And finally, I'd say we're one-stop shop. We try to meet as many needs as we can. Next slide, please. So you've heard we have about 1.2 million people living with HIV in the US. The numbers of new cases have gone down some. In 2019, there were almost 35,000 new cases, and in 2020, even less, but we're not quite sure about the 2020 numbers because of COVID. In 2020, 51% of the new diagnoses were in the South, and nearly half of all the HIV deaths from HIV are in the South. I don't know about you, but I find these numbers to be very disconcerting and unacceptable. And we're all working on trying to end HIV as an epidemic. Most of us are in these jurisdictions where we are getting this additional ending the HIV epidemic funding. It includes 57 jurisdictions. 29 of those are in the South. And of the 7 states that are included, 6 of those are in the South. So this whole plan hopes to reduce new infections 90% by 2030. But so far, our benchmarks are not looking that great. We've still got a lot of work to do to reach these kinds of numbers. And the sorts of activities that Mia described in the first presentation, I truly believe the stigma caused by some of these conservative policymakers further disenfranchises the very hardest hit populations. So when you have these laws being passed in places like Tennessee and Florida and Alabama, it's very frustrating to our work. It does not help our work. And then a big component for me is the fact that there's no HUD money, no real housing money included within the ending the HIV epidemic plan. Now, I will say there is some because Ryan White gets money through the plan, and Ryan White can do some housing, but Ryan White is not a housing specific law, and it really doesn't serve us well enough within the housing world. So next slide, please. Can we move to the next one?
We're on the next one here, Kathy. Are you able to see it?
Oh, no, but if y'all can see it, that's okay.
It said our government is siloed.
I'm sorry?
It said our government is siloed.
Yes, okay. So you've got 2 silos there in your picture, and it's very frustrating when you're working within the government because all of these agencies, if they're in different departments, they're in totally different worlds. So for example, Health and Human Services includes the Health Resources and Services Administration that administers the Ryan White program, which is huge. And then also under that department is the Centers for Disease Control and Prevention, which does almost all the prevention work. Then on the other silo, you've got HUD, the U.S. Department of Housing and Urban Development. And they manage the HOPWA program, Housing Opportunities for Persons with AIDS, which is a much more flexible program for housing people living with HIV. But because they're in different departments, it's hard, and different appropriation streams, it's hard to get them to play together. So next slide, please. Hopefully you're seeing the next slide. Within the ending the HIV epidemic version 2, I insist that it has to include more housing. And let me explain some of the reason for that. So we've talked about 1.2 million people living with HIV. Well, do you know that 1 in every 4 of those needs housing assistance at some point? But unfortunately, because HOPWA is a small program, only 2 in 5 people get the help that they need. So that's only 40% of the people who need help that are getting help. So I think it's really important to have some of the actual money from the ending the HIV epidemic moved into HUD's portfolio so that the Office of HIV/AIDS Housing can also participate. Next slide, please. So I often joke that HOPWA is a small but mighty program. You can do a lot of different activities with HOPWA. Of course, housing is the main component, but it also provides wraparound services. You can, sometimes even build new housing for folks living with HIV. The list goes on what services can be provided through HOPWA. But we know we have 1.2 million people in the US living with HIV. We've got 400,000 plus with housing needs. We've got 100,000 who we call houseless. Now, we call them houseless because they may not fit the exact HUD definition of homelessness, but people who are couch surfing or living with relatives that don't want them to live there, they are houseless. And yet, despite this great need, HOPWA only serves about 50 to 55,000 people living with HIV each year. So despite the fact that we know HOPWA improves medical outcomes, it increases viral load suppression, and it reduces behaviors that cause new transmissions, it's very difficult integrated within all of the HIV care. Next slide, please. So AIDS Alabama doesn't depend just on HOPWA. We have the second most homeless programming in the city of Birmingham, second to the Birmingham Housing Authority. And that's very important because we all know that homelessness causes oftentimes HIV, and HIV positive people are often homeless. So it's important to get a hold of some of that money. But one really interesting and innovative housing partnership that we've developed is with the University of Alabama at Birmingham 1917 Clinic. Now, the 1917 Clinic is one of the best clinics in the United States for HIV care. They've been in on just many cutting edge discoveries, and oftentimes have been part of the reason we have so many great scientific advances in HIV. But they were struggling with some of the viral load suppression among their patients. And so they did a survey to see what was missing, and you can guess what the number one need was. It was housing. So rather than reinvent the wheel, I think they made a brilliant move and called AIDS Alabama, the housing experts. So we were delighted to work with them. They spend some of their 340B money on this program, and we help to provide additional housing that their patients need, and sometimes even some things that other grants won't allow. So it's been a very successful program. Their viral suppression rates have really improved, and we've been doing this for about 5 years now, and we serve around 200 to 250 households each year through this innovative program. Next slide, please. So I can't stress enough how important it is for us to get involved in the policy work, because as Mia described, what happens in the policy world and in crafting these laws and statute totally impacts what we are able to do on the ground. So I have here 3 options for you to get involved. The first being the Southern AIDS Coalition. I was one of the original founders of SAC. It includes 17 jurisdictions. It's the CDC defined South with 16 states and Washington, D.C. And it's an unusual coalition because it's government, community, and business leaders working together to stop new transmissions and to build a better South for people living with HIV. Secondly, I have to mention AIDS United, which is probably the strongest advocacy organization on a national level. They work for social justice and true equity in ending the HIV epidemic. And then lastly, the Federal AIDS Policy Partnership, or FAP. I'm one of the co-chairs nationally of FAP, and we are a national coalition of local, regional, and national organizations, and we push for progressive federal legislation and policies to help folks living with HIV. Most of our work is accomplished through work groups. And trust me, there's a work group for everybody in FAP, whether you're interested in care, prevention, aging, research, prep, appropriations, whatever, we have work groups for that. So we would love for you to get involved in some way. It's important because I always say if we go away, the money goes away. And we need to keep fighting HIV until we find a cure. So thank you very much for your time today, and I'll look forward to questions at the end.
Fabulous.
Thank you so much, Kathy. Carly, if you can.
Thank you to Kathy and Hanek. And Kathy, thank you for mentioning AU so graciously. Yes, we do tons and tons of work, and I have to say I feel really lucky to be a representative of AU today. Next, we're gonna hear Gabriela Rodriguez, who is a dedicated Chicago-born advocate committed to eliminating stigma and discrimination experienced by the Latinx LGBTQ community in Central Florida. Her journey has been a testament to resilience and personal growth as she navigated through various challenges as a queer Latinx woman of color growing up in the South. Gabriela's mission is to reshape narratives, courageously stepping into roles that once felt out of reach, and inspiring others to embrace their identities and foster self-love, an ongoing process that requires sharing stories and unlearning preconceptions. So currently, she serves as the executive director of Q Latinx, a grassroots organization resolute in building a nurturing foundation and advancing inclusive practices within the LGBTQ plus Latinx community. Her dedication extends to fostering a compassionate and all-embracing society characterized by her grasp of both macro and micro approaches to care. Simultaneously, she maintains her role as a case manager at the Orlando United Resiliency Center, where they offer assistance to intricate needs and magnifying the voices of individuals with intersecting identities. Beyond her professional pursuits, Gabriela finds joy in spending quality time with her 3 wonderful children, her husky Ace, and her cherished queer chosen family. She firmly believes in the collective effort to create a world where every individual can wholeheartedly embrace their authentic selves and take pride in their identity. And I'm very much looking forward to Gabriela. So here she is.
Just one quick comment. I want to make sure we have time at the very end for Q&A. So please try to be concise. I hate to interrupt, but please go for it, Gabriela.
Thank you. And I'm grateful to be a part of this panel and sit alongside some amazing trailblazers that are leading initiatives in these spaces. So like they mentioned, my name is Gabriela. I use she, her, and ella pronouns. I currently sit as the executive director of Q Latinx, as well as a case manager in the community, working with those that were impacted by the Pulse tragedy in 2016. I think as a grassroots leader in these spaces and joining these conversations, we've been on the boots since 2016, being able to collaborate with others to uplift the various needs in trust building and those impacted by HIV. We realize that within our communities, we work with those that are that sit at the intersection of Latinx and LGBTQ. We are open to other folks and realize that we have a big need in our community when it comes to certain barriers to care. As queer folks, we're usually impacted by various challenges. I think one of our previous speakers from Tennessee was mentioning a lot of the policy work that's happening. It's usually copy-paste within a lot of different states, and we see a lot of people that are being impacted whether it be through conversations on the ground where we meet people where they're at local laundromats and barbershops. The need is pretty alarming, and we have a lot of people that are currently leaving the States in fear of not being able to just get basic healthcare needs, nevertheless being able to address their HIV, and really understanding that as intersectional folks, we have overlapping identities, and there really isn't a cookie cutter approach to addressing the needs and the risks of those living with HIV, right? I think when we're talking about our anti-trans and anti-LGBTQ and anti-immigration rhetoric currently happening right now, a lot of people are in fear of even asking questions to their healthcare providers, nevertheless being insured and being in care, right? So we're really having to seek those people out. I think one of our other speakers spoke about really meeting people where they're at. And we have several different initiatives that we've been able to trust build within these spaces. We have an initiative called One Wash at a Time, where we actually go to different laundromats once a month, and we bring other community partners with us because we realize collaboration is key in these spaces, right? And for folks to show up and say, hey, like, we're here and we're willing to help when you're ready, right? Being able to provide people with information outside of just their HIV needs is important. Through this initiative with One Wash at a Time, we've been able to bring hurricane resilience into the conversation. We've been able to bring food disparities and talk to individuals about, hey, where are you sleeping this evening? Addressing their housing needs and really understanding that people need to be able to be understood as holistic, right? And once we're able to focus on those pieces, then we can get to the medical distrust, right, that some folks have within our communities, and really talk about health and wellness and sexual health and wellness as just another component in our overall health and wellness, right? I think language justice, especially in the state of Florida, is key, right? A lot of our folks, if we're not being understood in the languages that we speak, how is the information getting across? So we've made it very important for us to not only address that with the health department, but also address that with other organizations coming in and being able to be like, hey, what does your materials look like? How are you approaching our Latinx community? And if you do need HIV testing and counselors, we have, I would say, like an army of individuals that are bilingual that are able to help in those aspects, right? I think it's important also to understand that when we're going into these communities, that we have to amplify the voices of those that are truly impacted, going to those leaders and individuals within our faith communities, within our communities that are mostly impacted, right? To be able to deliver those messages and really partner with them. And then lastly, I would say policy change, understanding that some of these systems weren't created for us or by us. So we have to really come together in finding innovative approaches in getting the information across to our communities and truly learning from one another and embracing the culture of continuous learning and growth within our spaces. And I would say you can see and we can invest in sustainable change by really committing to a long-term commitment, right? Really learning from others, being on this call and learning from others from across the nation, I think is really important, because then we can take it back to our communities and then change it up a little bit so that we can make it work for us. And I would say lastly, being the change that you seek, right? Commit to the solutions by being able to support equitable change in every aspect of life as we create a better tomorrow for everybody. So thank you.
Thank you, Gabriella. Thank you. Sounds so good. And at recognizing that holistic healthcare is something that is very dear to us over at Melanated Movement. I'm sure across everyone on the call, as we continue to recognize how so many determinants of our health can, lead to us living successful and thriving lives in so many aspects. So Next, we have Dr. Keisha Ashmead. She is a family nurse practitioner at Meharry Medical College, where she provides comprehensive care to people living with HIV and infectious diseases. Dr. Ashmead is not only a practitioner, but an educator, researcher, and manager. She earned a Master of Science in Public Health at Meharry Medical College, where she worked on clinical research trials. She later earned a Master of Science in Nursing, specializing in family practice at Tennessee State University, where she worked in acute care and internal medicine. Additionally, she earned an PhD EdD with a focus on higher learning and skill acquisition at Tribeca University. She's worked as an assistant professor at Meharry Medical College using simulation as an educational tool for medical students learning skills that are transferable to practice. She holds a national board certification with the American Nurses Credentialing Center as a family nurse practitioner and certification as an HIV specialist from the American Academy of HIV Medicine. So without further ado, Dr. Keisha Ashmead.
Hello, thank you. Can you hear me?
Yes.
Thank you so much for that. I'm like, whoa, who wrote that? I know we're pressed for time, and I know we have talked about a lot of statistics. And so we know that the South is the epicenter right now, and we're really concerned about our numbers and controlling our numbers. And so I'm going to try to edit as much as I can so we can get to the question and answer. So I will say we can skip the next slide, which is the data that's already been discussed. And you can skip the next slide. And then we can land on the next slide. Okay, so some of these things that I'm bringing out are going to be something that's already been mentioned. I just want to bring kind of a clinical perspective to it. And really, I'm just saying how it looks in the clinic, like how it looks in front of me with the patients and what we have to go through to work through some of these challenges. So it's already been talked about the Tennessee HIV preventative funding, which, you know, could be like an emergency or a crisis situation. Because we had to go through a lot. Well, we ended up getting in a little bit more money than we thought to support prevention, surveillance, and treatment options. So I'm grateful for the CDC stepping up and still giving us money for the community-based organizations and health departments, you know, being able to still provide services. And it's true, as was said before, you know, the focus probably of our governor is misdirected and maybe not at the at-risk groups than he thinks. But again, we have enough people and we need to continue to be a voice for those at-risk people so we won't lose it. Like she said earlier, you know, this is annually, so it's like you're fighting each year to acquire services for patients. I want to give an example of something that's similar to this with a patient. So I had a patient to come in to me. This patient had been receiving PrEP and was at a PrEP clinic. The patient did have insurance. The patient lost insurance for whatever reason. And a year later, they did end up acquiring insurance as well as their new job. And when they returned to start the treatment again for PrEP, they were tested and then they ended up being positive. And so, you know, that was a missed opportunity to kind of capture him in some kind of care. He was not aware of any other services. He just thought, I can't afford it. I'll wait till I get insurance and everything kicks back in. And unfortunately, this was the result. However, he's doing very well on his treatment and very adherent to his care. On the other one we're talking about, to me, that's big as well, as the gender affirming care. As was said before, there is a temporary ban on the Tennessee doctors for providing puberty blockers and gender affirming surgery to minors. There's some states that have even increased the age to like young adults, like college age, for receiving certain types of care. Now, right now it's temporary. So the courts will decide on that in September. So we'll kind of see you know, if this is going to be temporary, is this going to be something more permanent, and then how to navigate from that. And so that's one of the challenges as well. Even in my clinic now, we deal with adults, so 18 and older. This particular patient that I have, she is transgender female, and she wanted to continue her gender affirming care. And so I did refer her to Vanderbilt Transgender Clinic. So it was exciting. She was on the road to all the things that she wants to be. And so she did have a clinical visit there. Unfortunately, she found out that a lot of the things that she wanted to get done was not covered by her insurance. So we kind of went back to the drawing board. We really searched and see what her insurance would pay for and what was not considered something that the insurance would pay for. So like cosmetic, you know, components of that transforming. And so instead of, you know, kind of staying depressed or defeated, what we did was she looked at her, you know, what she could pay for, putting herself on a budget. And so, you know, came up with a plan where she can still, you know, move forward with her dreams and be the best, you know, version of herself. And so that's one of the ways that we were able to work around some of the challenges, even as an adult. And in this case, she had insurance with the gender affirming, you know, care. The next thing I want to talk about and bring some highlight to the cisgender women in the South. And there's so many things I can say about like the women. There's just a couple of things I wanted to highlight. You know, one is the knowledge of PrEP. And there's the statistics on that, like 2% who could receive it benefited from it. You know, that's a lot more that could benefit from being on preventative treatment. And then knowing their HIV knowledge of their HIV status. So 90%, which is pretty good, in 2019 knew their status, but the goal in 2025, even up to 2030, is to have 90% of the women to know their status. Adherence treatment, 63% of the women surveyed were agreed that they were adherent to their medications for at least for 30 days. And then the HIV stigma, so 31% of women felt that they experienced a stigma because of their diagnosis. And this is something that I do see in the clinic among my cisgender women. It's kind of hard to get them kind of engaged a little bit. And so there's some steps and things like that we really have to make sure that's in place. One, we have we do have a satellite community-based clinic, and she is there. Now, she doesn't want to see anybody. If it's not staff, she doesn't want to come across anybody because she doesn't want anybody to see her. She's, she has a lot of family. She's born and raised here. So what we do is we try to put her in a schedule where she doesn't interact with anybody. So, we get in, see her care. She has other issues with transportation. She also, we're talking about housing. She has housing issues, and so, and electricity. So we try to provide those services to her, and that has helped her actually stay in care and maintain undetectable viral load. And so those are some of the things that, other things as far as like abuse with partnership, mental health, as well as substance abuse, those are issues as well. So those services is like need to be provided to women so they can feel supported and not just kind of be invisible in this, journey that we're trying to do as far as fighting the epidemic. Next slide. So just staying on those topics as far as our opportunities for change in the South. So I gave an example about maybe, having insurance for PrEP and not having insurance for PrEP. And so we do have case managers here, which help us with our patients, making sure they're staying up to date or recertified on their insurance. And so I'll move on. Then for gender affirming, I want to make sure that we are speaking out. Right now, we're not really sure what the verdict is going to be because some people are even having to go across state lines to continue their youth gender affirming care. So that's a concern. And then also with women, making sure we give them that support. So it looks like we only have like 5 more minutes, right? So you can skip down to the, because I was ready. I had a whole bunch of stuff I timed myself to, but I understand. Best practices are very important. So we need to know, our patients need to know their status. And with that, we can either direct them to either PEP or PrEP, whether they've been exposed to, HIV, so they can be on the PrEP, as long as it's 72 hours within exposure, and then, or they could be on the PrEP. And that's something that we can definitely do. I want to just mention one thing about women. It's a little bit more challenging because it takes a little bit longer for the medication to reach therapeutic levels, more like 21 days with them. And then we do have a little bit more options with the Appeal Truvada and then the Apretude injection. So that's something that we can start having conversations about with our patients. It's just that maybe people who are not in those infectious disease clinic like I am, can have resources such, other doctors can have resources to kind of help them guide the conversations of bringing that up, or either testing. And so that's a good thing. Also, treatment is very important to know what our options are for, or best treatment for our patients. You can go to the next slide. And so with the best treatments, that leads us into like emergent treatments. So there's a lot of things that are on the horizon. Of course, we got our injectable Cabenuva. Most people want it for every 2 months and not that once a month, but that's another option. There's some other research options. They're not quite ready to be implemented into the public. So the implants, vaccines, vaginal rings, suppositories. We just have to keep up on the research. Next slide. All right, so just my call to action. We just need to stay in the race. All these things are hurdles, right? They're hurdles for us to jump over, for us to conquer. And and that's what we're doing. It's a race. It's a marathon. It's not a short, sprint. The next slide. Of course, we don't want to kick the bucket and just spill all the progress that we have made, so just the example with the young person with the PrEP, we don't want a person like that to fall through the cracks. And so we have to stay up on all the things, the policies, the treatments and things like that, to do offering wraparound care, because we offer even, OBGYN care, those things like that, to make our patients feel comfortable, seen, heard, and protected. Thank you.
Thank you so much, Dr. Ashmead, and thank you to all of our panelists. It was really insightful, and thank you for these resources as well. Someone did ask in the Q&A box whether we would share the recording. We do plan to share the recording, so you'll have that to review later in your leisure and to share with your colleagues as well. And so it was great to hear about how quickly Tennessee was able to mobilize in a crisis earlier this year. It was great to hear about the innovative programming, the language justice piece in Florida, and about the clinical piece around navigating insurance challenges, accessing gender affirming care among youth. And so there was one question that came up, which kind of aligned, Dr. Ashmead, with what you were mentioning on your very last slide here. And the question says, and I'm directing this to you, but also to all the panelists, so anyone please feel free to jump in. Contraception and sexual and reproductive health services are still very siloed from HIV/AIDS services, not only in the US, but also across the globe. How can we better work across these sectors? So this is the question. So I pose that to you, Dr. Ashmead, and anyone else that would like to chime in.
See, I think that's a really great question. I do think that we need to start getting training outside of just our regular provider care, like if you're internal medicine, so forth and so on, even the pediatricians. And so that, and I was given some information on, I think my last slide, to kind of see where the providers can get that information, because you got to have the conversations to know what your patient's risks are. And so for our clinic, we do offer that, where we have an OBGYN come in. And so we're able to offer both the preventative or treatment and the women's care with the contraceptives. And that's a big question. And you really need to know that, because if you're on treatment, there's some medications that interact with treatment. Now, the good thing is PrEP is really good. And so far, we don't see any interactions with the contraceptive. So those are conversations that we need to have more comfortable bringing it up with our patients. And I think we need to look at ways where other public providers can start introducing that information to the patients.
Thank you so much, Dr. Ashby. Would anyone else like to chime in on that? I think we can do one more question. I know we're at time. You can bear with us.
I'll just add very quickly that I think it's all so intertwined. I know that there have been times when maybe in the HIV world, we didn't want to get too involved in the LGBTQ world or, you know, and so on, but it's all connected. We all have to look out for each other because, you know, it may be Planned Parenthood that's being attacked today, but then it might be Tennessee and their HIV efforts tomorrow. So it's very important that we all work together on this.
Thank you so much, Kathy. So I know we're at time, but I just want to end, and I'm glad that we had, is someone speaking? Maybe that's just my voice echoing, apologies. So I just want to end on a kind of a positive note, and thank you, all of you, for having a call to action or an opportunity for folks to get involved with the work that you're doing. So if I said to you, you know, if you didn't hear anything I said today, please hear this. How would you fill in the blank at the end of that statement? Just your final thoughts for today. So I'll start with Kathy.
Never give up. You got to be an Energizer bunny, because the day we go away, our money goes away. And the day our money goes away, we quit providing these services and we quit working toward ending the epidemic. So just hang in there and keep fighting.
Thanks, Kathy. Thank you. Gabriella.
I would say continue showing up and leaning on each other.
Okay. Thank you. Mia?
I would concur with everything Kathy said, along with know your policymakers, understand the policies, get out and vote. Your voice matters, and we need all the support we can get.
Thank you so much, Mia. I know this is a hard task to summarize everything in one little statement. And Dr. Ashby?
Like I said, stay in the race, don't give up. Also, you know, be an advocate for your patients. And sometimes we don't know where to go. We kind of figured out what insurance would work for a patient in that scenario. And sometimes it can be overwhelming, but having these type of meetings and meeting each other, it really does help to know that you're a part of a community. So just advocate and don't give up, stay in the race.
Thank you. Well, thank you on behalf of Palladium, NMAC, and AIDS United for attending Southern Voices, Ending the HIV Epidemic today. We appreciate your participation. We ask that you fill out the evaluation that you'll receive by email shortly after the end of this presentation today. Have a wonderful week and feel free to be in touch with us at any point. Thank you all.